All right, ladies and gentlemen, great to have all of you on board. We are here live on Zoom as well as on Facebook. We're going live on Facebook as well, on the Amkana Facebook group, as well as on the Geo Iqbalian Facebook um, group as well. So hopefully people can reach us. If they're not able to reach us on Zoom, they can reach us on Facebook as well. And of course, this will be telecasted on YouTube as well as on the Facebook group as a recording. Now, we'll be talking about COVID-19 and Dr. Ahmed Ashfaq, who is an infectious disease specialist out in Oklahoma. He will be giving this talk on the evidence-based treatment, and he will be talking about the different treatment modalities and when they're supposed to be used. That is going to be fairly important in this current environment, as well as we will be talking extensively about vaccination, different types of vaccines, and we will cover American vaccines as well as the vaccines available in Pakistan as well. So do stay tuned. Um, I will move the floor over to Dr. Ahmed Ashfaq. Dr. Ahmed, how are you doing today?
Yeah, I'm doing good. Thanks, Umar.
All right,
Thank
so
you for the opportunity.
yes, Dr. Ahmed Ashfaq, you can please continue with your presentation. Thank you so much. And I would like to state one important aspect over here. Please do leave your questions in the comments area. We will be getting to your questions in the Q&A session. I will allow you to speak so you can directly ask your questions to Dr. Ahmed Ashfaq, so we can have an interactive session at the end. So please do send me your questions as well in case we have any bad connection, so I can ask your question directly if needed. Anyways, Dr. Ahmed Ashfaq, please continue. Thank you so much.
Thank you, Umar. So thanks everybody who's joining live. So we're gonna talk about the COVID-19, and first of all, this is my disclosure slide, um, and the learning objectives. So at the end of this session, so I hope you guys gonna have a better understanding about the symptoms and the severity of illness, and based on what is the severity of the condition, what would be the treatment options which you can offer to your patient population. And definitely, of course, we're going to know and we're going to talk about the vaccination. So first I want to talk about what are the coronaviruses. Coronaviruses are not new to the humans. We know there's a lot of coronaviruses, especially the common cold viruses, the four common in US. These are the strains, but they have nothing to do with COVID-19. These are just common cold, and without much um, causing any trouble to the humans. But then we know in 2003 we have what's called SARS and SARS-CoV-1, which was the severe acute respiratory syndrome. And we know that was also originated in Asia in 2003, and then about it spread to the 2 dozen countries. And then in in 2004, it this SARS-CoV-1 vanished from the world. So the scientists think about there was some genetic mutation, which the virus during the application, that's why the virus killed itself. Then we know about this called MERS. MERS is another coronavirus. It's called Middle East Respiratory Syndrome coronavirus, which we see the outbreak of this in Middle East, especially in Saudi Arabia. It is kind of considered as one of the deadliest coronavirus because about every 3 or 4 people out of 10 who acquired the MERS coronavirus, they usually die. But it is not that much infectious as the COVID-19. So before this COVID-19, we've been having these common cold coronaviruses, SARS-CoV-1, and the MERS coronaviruses. But as we know, in 2019, we saw that this novel coronavirus that was first detected in China, and then it caused the pandemic. We call it coronavirus disease 2019, and it is abbreviated as COVID-19. So what are the symptoms? Still, the most common symptoms we see is the fever, cough, shortness of breath. These are the most common symptoms, but as this virus evolved, we've seen most of the other symptoms, because these are all the symptoms which are also very common for other upper respiratory and respiratory viruses. But the unique things and the unique symptoms which are happened with this virus was mostly were like loss of taste and smell. Then we also see the headache, myalgias, and the GI symptoms as well. Here I'm going to take a moment um, for all of you guys to have a look into it, because this thing, the severity of illness criteria, is the key to assess our patient population, how to diagnose them, and based on the severity of their illness, we're going to be able to offer them and provide them the treatment options. So that's the key, because what happened in the past, or what's happening is we are just jumping into, and either we are over treating or under treating. So once we know, taking a patient history, and we are looking for all the symptoms of the patients, we can understand what level the patient stands, and based on that, we can offer help. So this severity, the SARS-CoV-2 or COVID-19 severity illness criteria is considered mild illness, moderate, severe, and critical. So the mild illness, when we have just general viral prodrome symptoms, that include fever, cough, loss of taste, smell, headache, muscle pain, and aches, but without lower respiratory tract symptoms like no shortness of breath. So that's mild illness. Then we call moderate illness when we have some shortness of breath, and we've been having low respiratory tract symptoms, and or we see a radiographic changes on X-ray, but oxygen saturation is above 94% on room air. So that person qualifies for moderate illness. Severe illness, anybody who has low respiratory tract symptoms, or their lung infiltrate greater than 50% and requiring oxygen saturation dropping to less than 94% on room air, and respiratory frequency greater than 30 breaths, so they qualifies for severe illness. This severe illness is the key where most of our treatment modalities gonna work and help, and that can prevent turning into a critical or severe illness. Critical illness, the people who have respiratory failure, septic shock, and multiple organ failure, and that is a point where we're going to see a lot of mortality, and which we saw a lot of mortality and deaths happens. So this is the key for our treatment options. But before treatment, we're going to talk about prevention, because again, prevention is the key. If we don't acquire the infection, because this virus, we don't know, there are so many odds there. We still don't know a lot of things. What are the long-term impacts? We've been seeing some acute illness, lot of morbidity and mortality, but we don't know still the long-term effects or impacts. Some people like having myocarditis, chronic renal failure, or kidneys issues, or multi-inflammatory syndrome, which we mostly see in children, but also we see in some cases in adults as well. So again, prevention is the key. Wearing face mask, social distancing 6 feet apart, and keep washing your hands with soap and water for 20 seconds. And again, now we have vaccinations, so the vaccines are the key. And all these preventive measures plus vaccination is the key that we can able to battle, and we can get rid of and come out of this pandemic. So what are the keys to the treatment? So most important thing, if you develop like when you've been in low respiratory symptoms and hypoxemic oxygenation, and if they become severe or critical ill, um, then high flow oxygens and the ventilation would be the key. Then we know the antiviral therapy, which is the most important one, and right now the most proven one is remdesivir. That's antiviral. Um, and there are some other proposed antivirals, but so far nothing shown any efficacy in the clinical trials. Then we're going to talk about immune-based therapy, which are, we know, convalescent plasma, some monoclonal antibodies, and some interleukin inhibitors like tocilizumab. We're going to talk about steroids, and then we're going to talk about, is there any role of any adjunctive therapy like supplements, or is there any role of antibiotics and anticoagulation? So go back to the severity of illness, and based on that, how we're going to treat. If a person is mild to moderate disease, in US we see, if because in the early phase of this infection, we find out like which are the patient population who is going to be at high risk for developing severe disease and high risk that they're going to be having a critical illness. So those we saw like elderly population greater than 65 years of age, or people who have high BMI greater than 40, mostly we see people who are diabetic, chronic kidney disease, or having any immunocompromised status. Those are the people we saw they develop a severe disease and they have high morbidity and mortality. Those people, if once they acquire this, we know they starting a symptoms or testing positive, so we're gonna have high risk. So we have some few things to offer, and those are those monoclonal antibodies against spike proteins of this virus. So they bound those spike proteins and inhibit the attaching of this virus to our lung cells, so they don't cause damage and prevent the hospitalization and mortality. So the one which is highly recommended are the two, which is bamlanivimab plus atezolizumab. This is Eli Lilly, and there's the region known one is casirivimab, and it's a combination of casirivimab and imdevimab. These are two monoclonal antibodies which is recommended by National Institute of Health and also from Infectious Disease Society of America. These two cocktails of antibodies shown reduce hospitalizations of those high-risk patient population. There is, like recently, there's a concern for developing resistance to bamlanivimab. So now it is discouraged to use alone bamlanivimab. So we are using in a combination of bamlanivimab plus atezolizumab or casirivimab or imdevimab. So this is people who are not hospitalized, we've been seeing in outpatient setting, and who has some comorbidities so they can have a risk. So giving those patients to prevent the hospitalization, so that help for flatten the curve and help to overburden the hospital system. Then we see another category of the patient. These are the hospitalized patients with mild to moderate disease. Again, mild disease, they have symptoms but no lower respiratory tract symptoms, or moderate disease, they have low respiratory tract symptoms like shortness of breath, but their oxygen saturation is above 94%. These patients, the only treatment they should not, we just be supportive of symptomatic care, should not be offering any treatment, because there is no additional or added benefits we've seen. There is some role discussed of convalescent plasma, but what we seen it, if the convalescent plasma is mostly recommended to those who are immunocompromised or people who are on any treatment um, uh, for the immunoglobulins depleting therapy. on treatment, or so those are immunosuppressed. Usually we see on those people, and so that's why it is recommended, even if you want to use convalescent plasma, just make sure they did not develop already antibodies. And we also saw like first 3 days of the symptoms, these convalescent plasma help. So these kind of people who have mild to moderate disease without lower respiratory, mostly symptomatic and supportive care, if convalescent plasma considered, it is recommended only we should be used in the context of the clinical trial. Now we're going to talk about hospitalized patients who have severe disease. Remember I told, who develop severe disease, develop low respiratory tract symptoms, but their oxygen saturation is less than 94%. So, but they are not into the critical care unit. They are not having septic shock or multiple organ failure. Those patients, the key other than oxygenation is steroids. We have clinical trial, randomized controlled trial evidence, which is recovery trial, mostly was done initially in the UK. Because initially with other coronaviruses, especially SARS-CoV-1 and MERS, we saw there was no additional benefits of steroids in those patient population at that time. But again, there was a limited data at that time, and there was some theoretical concern for delayed virus shedding and delayed clearance of virus. So that's the exact reason for initial mild to moderate disease, when there is no lungs involvement and oxygen saturation is above 94%, we should try to avoid steroids because it can delay viral clearance. So that's why I seen a lot of folks here and also in Pakistan, like anybody who has COVID, they we saw everybody just jumping into the steroids and starting steroids. So if the study showed did not any added benefits, but actually can be harmful, if we start the steroids, if there is no lungs involvement and there is no oxygen saturation is now dropping less than 94. As I said, one drawback is it delayed viral clearance. Another is developing opportunistic and secondary superimposed bacterial infections. So if patient is not hypoxemic, don't use steroids. But if the patient oxygen saturation drops 90 less than 94% and they have lung involvement, which we have an evidence with X-ray. X-ray is enough. We don't need to doing everybody HRCT or CT scan. So steroids, clinical trial, recovery trial that showed reduced 28 days, reduced mortality if we using it for dexamethasone 6 milligram for 10 days. So it showed between 70 to 34% decreased mortality versus non-steroid use. Other thing, convalescent plasma, again I said, preferably use in first 3 days. And right now it is recommended if you want to use it, use in the context of a clinical trial. And especially people who did not develop antibodies yet against COVID. Third is we're going to talk about remdesivir. Well, first I'm going to divide this COVID into two phases. One is we call the viral replicating phase, which we know is the first 7 days. And then we divide into the convalescent phase, or that can be the hyperinflammatory phase. So the first 7 days is the viral replicating phase, and the next 7 days is can be hyperinflammatory phase. So steroids has a role initially in this condition up to 10 days. Very few people it can be extended. Convalescent plasma, if you want to use it, use in the context of clinical trial first 3 days. Remdesivir, as we know, it is an antiviral drug. It inhibits the transcription of this COVID-19 virus. So it has a role in the viral replicating phase, which we see the first 7 days. The clinical trial, which was called Act 1 and Discovery trial, that showed the benefits, more benefit we saw if it was used for 7 days, especially in the first 5 days. So that's important. You need to identify your patients first. As soon as you know they have this severe illness, they have low respiratory involvement, oxygen saturation dropping, we need to use remdesivir. It's 200 milligram one dose and then 100 milligram daily for 4 days. Usually 5 days, 10 days, we don't know is there any additional benefit using in 10 days, but 5 days is important. So again, use in first 7 days. Can it be used later on? Very, very few cases we know virus replicating beyond 7 days. So again, the more roll in 7 days, you can maximum stretch up to 10 days. But beyond 10 days, I don't think so there is any significant role of antiviral medications. Then there's a drug called baricitinib. This is JAK inhibitor. It is immune-based therapy. Not much role, but we saw the patient who are having a severe illness, and for somehow we cannot give steroids if they have a contraindication to the steroids. In those patient population, adding a baricitinib with remdesivir in initially replicating phase, it is usually 2 weeks treatment, may helpful. Again, don't have um, much not much studied yet, but we saw some role, especially in that patient population, which was a part of Act 2 trial. In that one, so Act 1 was remdesivir alone was studied. In Act 2 trial, remdesivir and baricitinib was used, and we saw some additional benefits for little better recovery of those patient populations. So if for some reason steroids cannot be used, mainly because if there's a contraindication to steroids, so in that situation, baricitinib, which is JAK inhibitor, can be added with remdesivir. Um, tocilizumab is Actemra. So it's tocilizumab has really ups and downs during all this 1 year of pandemic. So we saw there's a role, no role, there's a role, no role. So what happened is, unfortunately, when initially the tocilizumab is interleukin 6 inhibitor, it was FDA approved mainly for the treatment for inflammatory conditions, especially rheumatological conditions like rheumatoid. But because it interleukin 6 inhibitors, and we saw after day 7 in COVID, the next 7 days can be the hyperinflammatory phase. In hyperinflammatory phase, there's a release of lot of we call the cytokine storm. And if patient is going into cytokine storm, how we identify patient has developed new fever, rapid progressively worsening of the oxygenation and lung infiltrates, and along with we see some inflammatory markers, especially CRP and interleukin 6. I know interleukin 6 is not readily available a lot of places, especially in the beginning. So, and even if it is available, it takes time to come. So we were mostly relying on CRP. So if if your patient population who qualifies for severe or critical illness disease, they've been developing a new fever, rapidly progressing infiltrates, and their CRP is trending up, and the patient is already on steroids, and majority of those patients beyond day 7 of their symptoms, so those patients can be in cytokine storm. If there is no absolute contraindication, which is um, if you are if your procalcitonin is not high, means you are not suspecting a superimposed acute bacterial infection, and patient liver enzymes are not 10 times of upper limit of normal, in those in that patient, you should use now tocilizumab. It is called Actemra. It is given as 8 milligram per kilogram times 1. Another dose can be repeated. It is weight based. One thing we need to, again, I'm going to emphasize, because this is strongly it's immune based therapy. It is, you are causing your patient severely immunocompromised, and it has a long half life, more than 2 weeks. So you need to make sure, because these patient population should not have any active bacterial or fungal infection, because otherwise you're going to be jeopardize that patient health if we're going to be using it. So the clinical trial, initially we saw there's not much benefits, but recently two clinical trials which showed that there is mortality benefit if we use tocilizumab who already been on steroids. So patients who are severe illness or critical illness with rapidly progressive disease with greater than 75 of CRP, and those patients along with steroids, we should be using Actemra or tocilizumab, which is an interleukin 6 inhibitors. Now we're going to talk about hospitalized and critical care and patients who develop a critical disease, patients who are ICU needing minute ventilation or septic shock or multiple organ failure or on ECMO. Those patients, again, steroids, again, convalescent plasma if they are early in the clinical stage, roll of remdesivir if they are in first 7 to 10 days of their symptoms, and again, use of tocilizumab along with steroids if they are worsening oxygenation, worsening infiltrates, and their CRP is greater than 75 milligram per liter. Those patients are um, kind of a target population where we should use. And these are the two trials which were recently showed benefit. One is the recovery trial, that's the same similar, which showed the steroids benefit, and the RAMCAP trials. These two trials showed um, that there is um, some role. So now the current guidelines suggest use of tocilizumab in severe COVID disease or critical disease along with steroids. Now we're going to talk about some other stuff which is like definitely either previously used or people are still currently using it. So there are studies done and they did not show any benefits in humans. So that's why the current guidelines recommend against use of hydroxychloroquine alone or hydroxychloroquine azithromycin or Calitra, which is antiretroviral HIV drug, lopinavir, prosritonavir. So the clinical trials did not show any benefits for using these medications in humans. In vitro, there was some showed, but again, in human clinical trials. So this is strongly recommended against use of these medications. There is an antiparasitic drug which is called ivermectin. Ivermectin is also being used a lot in different part of the world. Also, we've seen some usage in US as well. Um, the clinical trials, there was a mix, some clinical trials, but those are not well studied, showed there may be some benefits and some, but there is some serious concern about how much we're gonna reach a significant therapeutic level of the drug in humans, the and safety issues. So there is currently their suggestion against use of ivermectin. If there would be any use, it should be used only in the context of clinical trial. So that's important. If there's critical trial happening, then only should be used ivermectin. In clinical trial, other than there is, should not be used. The same thing is antibiotics. We've been seeing it. Everybody who has COVID, everybody is throwing antibiotics. This is a viral infection, so there is whatsoever no role of antibiotics until unless you have strong evidence there is a superimposed bacterial infection. For that reason, you have developed a new consolidation in the lungs, and you have elevated procalcitonin level, and you have a positive culture. If you have a positive bacterial culture or you have elevated procalcitonin along with it, um, then you should use antibiotics. Otherwise, should not be using, because one is you are developing resistance, and also those people already been having a severe illness. So by adding the antibiotics, you are adding additional resistance and adding additional adverse events. So recommend against use of hydroxychloroquine, azithromycin, cletras, suggest against use of ivermectin and antibiotics. Then we're gonna briefly talk about the anticoagulation. So we've been seeing it, everybody, we've been seeing they're throwing into Eliquis and Xarelto everywhere. So one sure, there is there's no recommendations to everybody. You just, even if they are mild to moderate disease, just start doing their D dimers or other. There's no recommendations to do those patients any of those labs. People who are hospitalized, we know, like severe disease or critical disease, definitely role of um, prophylaxis, DVT prophylaxis, and if there's no contraindication, use it. But do we need to use high dose anticoagulation in those patients? So insufficient data to recommend either for or against using high dose anticoagulation in those patient populations. So right now, there is no recommendations from the and there's no guidelines for those. So if you see, because we know it's more COVID is also like very thrombotic disease, and we've been seeing a lot of uh, clottings and PEs or DVTs. But again, which patient population we should be using, which we should not, we don't know yet. So there's not sufficient data to recommend high dose. Um, if I would say there is some like patients who are not in the hospital and they have high risk disease concerning for, so I think there are some small studies and suggestions coming up, like even aspirin, low dose aspirin would be probably enough, but I don't see there's any role of using Xarelto or Eliquis. But I'm seeing it, everybody is like who developed COVID, um, we are recommending and prescribing Xarelto or Eliquis. And there's no role for those. Um, Supplements. That's the same thing. Everybody who developed COVID is on vitamin C, vitamin D, and on zinc. Here's the thing. People think about there is no harm for using those, so why not use it? I mean, that's fine, but the problem what happened is we some of, especially vitamin D, some of these are not benign, and actually we recently admitted one patient with vitamin D toxicity and requiring plasma exchange and very severe condition and admitted in ICU. So because what happening is like everybody's prescribing, and patients end up like using 2, 3, 4 formulations of vitamin D and causing the vitamin D toxicity. So again, all those supplements, there is insufficient data to recommend either for or against using. So that was all about the treatments. So now I'm going to be talking about the vaccination. As I mentioned earlier, so the most important thing which is, we always know prevention is better than cure. So vaccine with all those preventive measures, face mask, social distancing, washing hands, with vaccine is the key to fight against this pandemic and to come out of this pandemic. I think there is a consensus between all the scientists and medical community. Without the vaccines, we don't think that we can come out of this pandemic. So there are, like, right now, we know there's the few vaccines already been in the market and we've been using it, and some are already in the pipeline. The major vaccines which we know and we're going to talk about are the Chinese, Russian, UK, and US. First, I'm going to talk about the Chinese vaccines because these are the vaccines, the two of them, the SINOPHARM and SINOVAC, are going to be the one major which we're going to have in Pakistan. So first is the SINOPHARM, which has already been in use in Pakistan, and as per my knowledge, I think um, couple 100,000 people already got those vaccine, and actually this vaccine was also studied in a clinical trial. Phase 3 clinical trial was done in Pakistan as well. It's an inactivated virus vaccine, and it is required 2 doses 21 days apart. And the phase 3 clinical trial was conducted in 7 countries including Pakistan. It was approved in China for emergency use, but now also been used in UAE, Bahrain, and Pakistan. So, what it is, there is the phase 3 clinical trial was conducted, but data was is not released yet. But whatever they reported um, it was not released for the peer review or not released in journal. But whatever they reported, it is 79% effective. But the company reported, but the UAE government reported it was 86% effective in UAE. So those are very encouraging numbers. So one thing which I'm gonna mention about, like, okay, we know the phase 3 clinical trial data is not released yet, but we first of all, we this is considered gonna be um, safe vaccine because inactivated virus vaccines is not new to us. We know we all got those vaccine in the form of rabies, polio, rabies too, but polio. So polio, I mean, this is kind of the same. So most likely it's going to be very safe. And we know it was used a lot. I mean, it's already been used in clinical trials, and we did not hear anything or any adverse effects. Actually, probably from some of our family members probably were in clinical trials. So, and I know some people who were in clinical trial, no symptoms whatsoever, no adverse effects, no adverse events. And also it was already been used in China, no adverse events reported, and also right now being used in UAE, no significant adverse events reported over there. So I think it is going to be very safe. As far as the efficacy data, although it is not released, but we know what are all the COVID vaccines are coming, and they are showing right now and definitely a very decent efficacy. So the key is, like, we know even the flu vaccine, we see those were not very effective vaccine, 40-50% effective, but they prevent significant drop in the number of cases, even with the flu vaccine, people who get the flu vaccine. So if this vaccine, any vaccine who is COVID vaccine above 50% efficacious, they're going to have a huge and significant impact for spreading of this virus. So encouraging numbers for the Sinopharm vaccine. So I would encourage people, anybody who is currently have the opportunity to get this vaccine, they should be getting it, and they should go for it. So The other vaccine is another Chinese vaccine, which already has a phase 3 clinical trial conducted in multiple sites worldwide, including Brazil, Chile, Turkey, Indonesia, and Philippines. Again, 2 doses. Encouraging number come from Turkey. They say it was 83 to 91% effective. Indonesia was 65% effective. Brazil, we had the mixed numbers, 50 to 78%. So again, the 50% usually was against those which was a significant Brazilian variant, which showed some resistance. But again, as I mentioned before, any number, these numbers are arbitrary. Different strains works different ways, different vaccines. So whatever the vaccine available, we need to get that vaccine because it would help um, to cut down the transmission of the virus. Um, we know also about the Russian vaccine. That's another potential vaccine which we are hoping probably going to be in Pakistan. This vaccine, it is viral vector vaccine. There are two different strains of adenoviruses were used. So that's what is important to get both vaccines. The one vaccine, first vaccine has a different adenovirus, hemoadenovirus, and the second one is the other one. So 2 doses, so both doses should be taken. Again, they recently released their clinical trial data and it was very encouraging. It is 92% effective and it is regular fridge storage, so it is going to be easy to store and easy to administer. So it this vaccine is also very effective and the potential vaccine which we going to be hopefully seeing soon in Pakistan. So that would be definitely encouraging number. Another possibility which I heard may be available in Pakistan, it's already been used throughout the Europe, especially in UK. And actually, it was given a lot in UK, and that's why we've seen a significant drop in the hospitalization in UK. Um, there's little lag in the Europe, so that's why we've been having seen some lot of cases in other part of the Europe, but not much in UK. So AstraZeneca, it is viral vector based. It is this virus is genetically modified chimpanzee adenovirus. 2 doses showed variable efficacy between 62 to 90%. Again, different variant um, showed different efficacy as all the other vaccines. Um, in just recently, a few days ago, the US trial data was also released and it showed 76% effective. So that's important because it is 76% effective at a time when this study was done, when the trial was being done, there was a lot of um, um, cases were in US at that time, and there were some resistant strains were there too. So that's very encouraging number. It is also stored in a regular fridge temperature, and it is very affordable to all those countries who cannot afford because of the cost and also cannot afford because of other vaccines storage issues. So this is there is some issues about which were concerned about some blood clotting and DVTs, but when they look in the data, so far there is no strong evidence because the number of DVTs which we seen in those cases who got the vaccine, actually it was not more than what you can expect in that population anyway. So no big concern. So if it would be available in Pakistan, I would encourage anybody who can get this vaccine, they should be. US vaccines, we know the first two who came were the Moderna and Pfizer. Those were new technology in a way we can say because that's the first mRNA based vaccines, but it is not new to the scientists because we already been studying for um, Zika virus and also for HIV virus. But and for first time being used in humans. It is messenger RNA based, and that some people are think that this new technology of the vaccines, they may revolutionize the vaccines, because the good thing about this kind of vaccine is they can easily modify. If there are different resistant strains are coming, they can easily modify in a short period of time, and can adjust as if the virus is changing. Those are the both of them are 2 doses. Moderna is 28 days apart, and Pfizer is 21 days apart. Clinical trials showed 95% effective, um, even with some little bit drop with those new variants, especially South African one. But again, way better than which we even can expect. So main their issue is storage, because those are the mRNA based, very fragile vaccines. So we need to store them on between -20 to -70 degrees centigrade. Just recently came a Johnson and Johnson. The good thing is about Johnson and Johnson, it is one dose vaccine. It showed efficacy of 66 to 72%, and it is also a vector-based, adenovirus vector-based vaccine. Um, the last one, which is just another vaccine, which is just going to come out very soon. It is a phase clinical 3 trial conducted. It is again, um, but it is different vaccine. It is a protein-based vaccine, and it's going to also have 2 doses, and it showed efficacy up to 96%. So this is all about what I want to say about the treatment and the vaccine. One thing which I want to focus about vaccines and those numbers. Believe me, which what are seeing those numbers like between 50 to 96%, those numbers have importance, but in the end, one thing which we know, all these vaccines, including Chinese vaccine, including Russian, UK, and US vaccines, all these showed a very above more than 85% reduction in developing into severe disease or patients being hospitalized. So the most important thing which we need for the vaccine is not to get like mild or moderate disease. The main target of the or main reason for the vaccine is to prevent severe disease, to prevent hospitalization, and to prevent death. So all these vaccines, more than 80%, they are preventing all of them to develop a severe disease or hospitalization. And so far, all of them 100% no mortality. So that's the key. So the important is people talk about which vaccine I should get. No, which vaccine is available, you need to take that vaccine, because all vaccine in the end achieving the same goal, no hospitalizations, no deaths. So thank you very much, and I'm gonna um, go back to Umar so we can start the question and answer session.
Excellent. Thank you so much. This was a very comprehensive discussion. Thank you so much, Dr. Ahmed. We have a few questions coming in the chat and different sources that I will be going over. If Dr. Usman Hafiz is available, he has a question. Please unmute your mic and you can ask your question directly. If not, then I will ask your question for you. Dr. Hafiz, Dr. Usman Hafiz, please.
Hello. My question is, when a patient is get infected with the COVID-19 strain, after recovery, how much duration is safe to get the next dose of vaccine
Okay.
if he's not previously vaccinated?
So yes. So it depends if the patient did not receive any dose of the vaccine and they got COVID-19. So when they should get the vaccine, if the patient did not receive convalescent plasma, or if they did not receive those monoclonal antibodies which I mentioned, emtricitabine and casirivimab. So then once they recover and they don't have any clinical symptoms, like no, not having any fever and other those or respiratory symptoms, then they can get the vaccines anytime. But if they received plasma or those monoclonal antibodies, then they have to wait for 90 days. So 90 days wait if they receive plasma or those antibodies. But if they did not, there is no timeline. Actually, we encourage to get the vaccine because vaccine actually boost up their immunity very significantly after when they recover from the infection quickly, because when you have the infection you develop antibodies against the whole virus, but when we give the vaccine we target against the vaccines against those spike proteins, so we see very high, so it will be very protective. um, Other scenario, you got the first dose of the vaccine and before you develop immunity you get the infection, so because your next dose is going to be 21 days when we should. So one thing we know, if you got the infection, your second dose can be delayed up to 6 weeks safely. So if you got the infection and if you completely recovered and you're still in that window, it's okay. You can go ahead and take it. But if you're not completely recovered and those 21 days are already been coming and your next dose is coming, so you can delay up to 6 weeks safely. But even
Dr.
if more delay happens, you don't need to start over the cycle. You can get the second dose anytime. But up to 6 weeks is relatively very safe.
And
Dr. Osman, yes, please. Go ahead, Dr. Osman.
I have a second question in this context. As these are not 100% efficacious, about 60 to 80% efficacy of this vaccine that is available in the Pakistan. If we right now and SINOPHARM, if we get infected after the 2 doses of the vaccine, mostly after 2 to 3 weeks after the second shot, which is most probably the period we have developed antibodies in our system. Can we, after recovery, can we take the next dose of any other vaccine which is available in the Pakistan, or it is not efficacious if we got infected from the previous one?
So yes, what we can do at that point is like you got 2 doses and still got the infection. But again, we need to know what, so if we have the antibodies, so we can see what would be the antibody titer. Because if you, with the vaccine, if you develop some antibodies but still got the infection, but once you got the infection, that probably also going to gives you the immunity. So if you have a boosted immunity, so I don't think so we need to get another if you already developed the antibody. So it's important to get how much is your immune status, what is your antibody titers. So if you have a significant titer in your body, you probably don't need to get additional. Now question comes is how long this antibody and immunity gonna last. We don't know yet. We know with after getting infection, we get the immunity up to 90 days, but somehow some cases we are seeing even longer. And with the vaccine so far, like we've seen 5 6 months. But again, we are in the phase of trial when we're gonna know more about after infection how long the total immunity lasts, and after vaccines how long immunity lasts. But I think back to your question, if you got the vaccine, you got the infection, you need to know whether you developed the antibody titer or not. If you did not develop any immune response, then we probably need to go for should get the other vaccine. Otherwise, if you develop already significant immunity after getting vaccine and then later on the infection, then you don't.
Sir, I have a question.
Yes.
So the patients who are undergoing treatment for rheumatoid arthritis, like they're on steroids or some other immunosuppressants, how about them? Can they get vaccinated while continuing the treatment, or they should stop it for some while and get vaccinated afterwards?
No, there's no need to stop any of their treatments. So they can go and they should be vaccinated. And actually, we know those are the immunocompromised people. They in clinical trials, some of those immunocompromised patients were included in the trial, especially the HIV and some immunosuppressive and some cancer patients were included in the trial. And those are the patients actually more get benefits because they are the one, if they're going to get the disease, they're going to be the one who's going to chances to develop a severe disease. So they are the one should be getting, and there's no need to hold their current treatments.
Dr. Imran, do you have any follow-up or any additional questions?
No, sir. Thank you very much. I have got my answer. Thank you.
Excellent. All right, so we have a few more questions regarding some biomarkers. I know you mentioned CRP, and that is essential when you are trying to investigate if the patient is deteriorating quickly. Other biomarkers are being used, ferritin as well as LDH. What is their role in assessing treatment and changing in the level of care for the patient?
Yeah, one thing again, I'm going to emphasize, don't do those markers, including CRP, if the patient is mild to moderate disease. The role of those markers to looking into it, assessing it if we have severe disease or critical illness. So CRP, so ferritin and LDH, they can also be helpful. The only issue with them, like they because they're also acute phase reactants, so we can see it, they can and there with some other condition as well. So if the patient has chronic kidney disease or end-stage renal disease, they're going to have high ferritin levels, and also LDH if they have some other conditions, clinical conditions, especially malignancy. So or lymphomas. So CRP is very crucial because CRP fluctuates very quickly and they go up and down quickly as compared to ferritin and LDH. They take some times with the changes in the clinical conditions. We use ferritin and LDH as well. So initially we use, like, definitely CRP is greater than 75 and ferritin is greater than 1000 and LDH is greater than 500, or are the markers when we consider that patient is going into cytokine storm. But when we conducted this clinical trial, to simplify thing, I think the CRP is the most important marker. So you can do other, including interleukin 6 levels, ferritin, LDH can be helpful, but I think in clinical trial, the most important markers is the CRP.
Excellent. Another question received, and you touched on this topic about anticoagulation in COVID patients. So some people are suggesting a possible cutoff for the D dimer, above which they're using anticoagulation of different types in nature. What is your information on that?
So as I said, so far, so NIH, National Institute of Health, so when they um, gave their guidelines, so they were saying, first of all, mild to moderate disease, no need to do those testing at all. If the patient who are hospitalized, severe and critical, so those patients can be done and assessed, but again, case to case basis. So far, there was no clinical trials showed any definitive answer. So when they're saying it, they said like not enough information at this point suggesting in favor of or against use. So if the patient doesn't have any contraindication, prophylaxis dose, yes, can be given. Which patient can be given high dose? It is very difficult because we've been seeing some people like a lot of issues. I've seen some cases they were getting stable and then because of anticoagulation use, they had a significant bleeding. So prophylaxis use is fine, but high doses based on those markers, we don't have any strong evidence-based data at this point.
Excellent, excellent. Right, another question, let's get to it. Another question that we have is, so in the hospital setting, when patients are worsening in their severity, they are progressing downwards. So in that situation, some people can be maintained on high flow oxygen as well as BiPAP and CPAP. So what is the cutoff after which you think people need to be intubated? They need to be moved to the ICU?
So it again, that was at that time the clinical assessment of the patient at that moment, because what happening is, I mean, there was some concern the people who requiring ventilation, the mortality is very high in that patient population. So, but on the same side, we should not be waiting or wait too long. So, if the patient who require, so best thing is as long as the patient can be maintained on high flow oxygen with the vapotherm and the BiPAP, that's fine. But if the patient mentation is deteriorating, I think at that point there's a higher risk for developing aspiration. So, and other complications. So in that moment, the patient needs to be intubated. But again, that's a clinical assessment. I think there is no definitive or any number which can be given.
All right, excellent. Thank you. And yes, that has been the experience. All right, thank you so much for joining, and thank you so much, Dr. Ahmed Ashfaq. We want to pay respects to people's time, and we have crossed an hour so far. Excellent session. Please, if you have any further questions, you can please post questions on the Facebook links. We will be having a recording that is going to be posted on the Facebook page as well as the group, as well as on YouTube. We'll share that link as well. Thank you all for joining us. Thank you so much, Dr. Ahmed Ashfaq. We will conclude this session. Thank you so much.
Thanks for having me.